Hi everyone, my name's Faye. I'm one of the JMOs at Nepean Hospital, and today we're going to be talking about common fractures. So in this presentation, we'll go over how to work up a fracture in the emergency department, some simple rules to guide you as to what types of investigations you can order, and the pros and cons of those different types of investigations, as well as some common fracture types that you'll see, the treatment, and some cases at the end. So when someone first walks into the emergency department, the first thing you want to do is take a proper history, asking them what exactly happened, how they got injured, if someone else was around that can tell us something extra about what happened, are there any witnesses around, and if they've hit their head or neck anywhere. These are important aspects to always get. The clinical features of the thing that is injured, check for redness, swelling, deformity, skin breaks, as well as neuromuscular compromise. Always check the distal sensation as well as motor movement, and have a feel of the actual temperature of the limb and capillary refill. Next, you want to start thinking about the need for investigations. Do you need x-rays or CTs? And things to always look out for are child abuse and domestic violence. Although these things are uncommon, it's important to keep these issues in the back of your mind so that if they do occur, because you've thought about it, you can actually pick it up. Okay, so investigations wise, once you've taken the proper history and clinical examination, you're thinking, do I need to actually scan this person? Do they need x-rays or do they need CTs? One relatively easy way to figure out if they need an x-ray is to follow something we call OTTAWA knee, ankle, and foot rules. So these rules were invented by these guys back in Canada who were in Ottawa at the time. And they made these rules because they found that a lot of patients who came in had x-rays done way beyond what was necessary. So these rules were made to reduce the number of x-rays taken in the emergency. So if a person did not have any of these 5 factors, then they had a sensitivity of 98.5, then there was no fracture involved. So the 5 factors are age 55 or older, tenderness at the head of the fibula, isolated tenderness of the patella, inability to flex the injured knee to 90 degrees, and the inability to weight bear. Now, it's important to realize that these rules cannot substitute clinical decision making, but they are a good guide to helping you decide whether a x-ray is needed for a certain type of injury. Now, the ankle x-ray indications after an acute ankle injury are bony tenderness at the posterior edge or tip of the lateral malleolus, which is indicated by A, bony tenderness of the posterior edge or tip of the medial malleolus, as indicated by B. So those are both the green zones, or the inability to weight bear. So again, it's if all 3 factors are negative, then the chance of there being a ankle fracture is extremely low. So the OTTAWA ankle rules would then suggest an x-ray is not needed under those circumstances. The OTTAWA foot rules are bony tenderness at the base of the 5th metatarsal or bony tenderness at the navicular. So that's the midfoot zone. So you can have a squeeze of the midfoot, and on both the medial and lateral side, you'll see both the navicular as well as the base of the 5th metatarsal. So in summary, the OTTAWA rules stipulate that if the patient is able to weight bear immediately after injury and they don't have the associated tenderness, then it's likely that they don't have any fractures and can go home on simple treatment. But if they have an inability to weight bear and have the isolated patellar tenderness, head of fibula tenderness, the inability to flex 90 degrees, or for the ankle, the posterior lateral and medial malleolar pain, or the navicular and 5th metatarsal midfoot pain for the foot, then you really should be getting an x-ray. Some tips while using these rules is if the patient is intoxicated or uncooperative, if there's other distracting injuries, if there's diminished sensation in their legs or gross swelling that prevents proper examination of the malleolar bone tenderness, that the rules are not as useful under these circumstances. And bearing weight, remember, counts even if the patient is limping. So as long as they're not holding on to anything and you're asking them to walk forward, if they're able to do so, even if they're limping, that's totally okay. And always be cautious in patients under age of 18. So again, remembering that child abuse is there and you need to be aware that it can happen. So investigations wise, x-rays are your first point of call. Remember that you need two joints with two views at 2 times, pre and post reduction. And x-rays have a low sensitivity for stress fractures. CT and MRIs, however, not routinely done. There's quite an increase in cost as well as radiation associated with CTs. There needs to be more pre-op planning. MRIs are very scarce and very difficult to perform acutely. Assessment of associated injuries can be quite important sometimes, and so CTs and MRIs are great at looking at soft tissue injuries. Or if there is an inconclusive x-ray finding, then CTs and MRIs can be very useful. So if you look at this x-ray image, you can notice that the third metatarsal has an oblique fracture through the midshaft, and everything else looks okay. But if you look at a different view, then you can also see that transverse fracture of the second metatarsal that was quite hidden in the first view. So it's always important to get two views. Fracture classification is important to know because when you describe a fracture to someone else, you should be using the correct terminology. Open versus closed is if the wound is open or not. Transverse fracture is straight across, oblique, quite self-explanatory. Spiral is more of a 3D shape, and we'll have pictures of that later. A compression is when there is a vertical force along the shaft of the bone and they've impacted into each other. Comminuted is when the bone fractures into multiple segments. Avulsion is when a piece of bone is actually pulled off. And green stick mainly refers to children's fractures that have a cortical break on one end, but because they're more malleable, do not have that cortical break on the other side of the bone. Now we'll go through some common fractures. So within the forearm, you'll have Colles fracture, which is a fall on an outstretched hand, and it's the fracture of a distal forearm with dorsal displacement. So you'll have that classic dinner fork deformity, and it's that fracture of the distal radius and that dorsal angulation of the distal aspect of the piece that has broken off. A Smith's fracture is fall onto flexed wrists, and it's the fracture again of the distal radius, but this time it's displaced ventrally, and you'll get that garden spade deformity. So if you look at the top right picture, that sort of looks like that, little step down of the garden spade on the lower picture. Now we have Monteggia fractures. It's the fracture of a proximal third of the ulna with dislocation of the proximal head of the radius, and these are more common in children. And the opposing one is the Galeazzi fracture. It's the fracture of the distal third of the radius with dislocation of the distal radial ulnar joint. And an easy way to remember this is using the acronym MUGR. So Monteggia is ulnar fracture with dislocation of the radial head, and Galeazzi is the radial fracture with dislocation of the distal radial ulnar joint. So in the acronym, M fracture U, G fracture R. So if you fracture the ulnar, you'll have dislocation of the radial head. If you have fracture of the radius, you'll have dislocation of the radial ulnar joint. And both of these are fractures of necessity, which means they need to have an operation, most likely an open reduction and internal fixation. Scaphoid fractures. So these comprise of 60% of all carpal fractures. And again, it's also from a fall on an outstretched hand. Now, main issues are non-union and avascular necrosis, mainly from the fact that the blood supply to the scaphoid is from distal to proximal. So when you fracture it, that most proximal part of the scaphoid bone no longer has any blood supply. And an easy way to look at whether the scaphoid is fractured or not is you can test it using telescoping. So pulling and pushing the thumb up and down will directly impact into the scaphoid, as well as if you look at the dorsum of your hand or the back of your hand and try and lift your thumb up, you have extensor pollicis longus and brevis tendons. And if you poke right into the middle of those two tendons, that's where your scaphoid is. And if that location is tender, then you can suspect a scaphoid fracture. And on imaging, you can ask for scaphoid views as well, which helps look at these scaphoid fractures. A boxer fracture is the break of the fifth metacarpal near the knuckle. And so that's when someone hits an object with a closed fist and you get that depressed knuckle. So if you look at this guy's hand, the fifth metacarpal, so that knuckle looks a little bit lower than it normally should. And this is usually when someone punches something that's quite immovable or hard, and the force is not translated through the first two metacarpal bones into the radius and then distributed throughout the length of the arm, but they've hit it laterally and onto the head of the fourth or fifth metacarpal, and that's where the fractures tend to happen. And it's usually with a volar angulation. Ankle fractures, you'll have lateral malleolus most common and bimalleolar second. So bimalleolar is the fracture of the lateral and medial malleolus, and they likely occur from sports injuries and running. So if it's the medial malleolus, that's the tibia, and the lateral malleolus is the fibula. Next are neck femur fractures. So these are very common in the elderly, especially after a fall. Mortality from this type of injury is extremely high, 25 to 30% at 1 year, and this is mainly because of pre-fall cardiovascular, pulmonary, or neurological issues that led to the fall itself, as well as post-surgical complications like infections and pulmonary emboli that tend to occur. So if someone does have a fall, you'll tend to notice there's external rotation, abduction, and shortening of the leg that's been injured. As well, there is a avascular necrosis risk because a major contributor is the medial femoral circumflex artery, and that swings around. So if you fracture the neck of the femur, then that blood supply is cut off from the head, and the head is likely going to die. So treatment in general is wound care, pain management, antibiotics, and management of the actual fracture, which include anatomical reduction, immobilization, and fixation. So conservative management indications are for stable fractures, which are fractures that do not have a lot of displacement, so the actual alignment of the bone is still there, or pediatric fractures, so even if there is quite a bit of displacement, the pediatric population tend to heal very well. So when you are going with conservative management, it's mainly the usage of splints or casts. On the right-hand side, we have an example of a sandwich cast. So you have both a front slab in place. Also making sure that the front and back slab have that little space in between. You never want them to be touching. And if they do, it's the reason why we don't want them touching is if there is swelling to the forearm in this case, you want there to be able to have room for it to expand. And if it's circumferential, then you can be causing a compression injury, which leads to compartment syndrome. In the next slide, we have examples of a long arm cast on the very left, and those are for midshaft humerus and ulnar fractures, a thumb spiker, which are used for both ligamentum injuries to the thumb or scaphoid fractures, and foot casts on the right hand side are mainly used for ankle fractures. Moving on to surgical management. So these are for open fractures, unstable fractures, and severe displacements. So you have two types of surgery, either internal fixation or external fixation. Internal fixation means that the screws and plates are on the inside of the body, whereas external fixation, the screws as well as the hardware is actually on the outside of the body. So indications for external fixation are when you need to stabilize severe open fractures, severely comminuted and unstable fractures, stabilization of infected non-unions, and if you have a lot of soft tissue injury of surrounding the fracture itself, like with a burn. So in external fixation, you are allowing the soft tissue to heal, but also able to maintain the alignment of the fracture while the soft tissue does so. Complications of surgery. Acute complications are neurologic and vascular injury, compartment syndrome, infection, and postoperative DVTs and PEs. Long-term complications include avascular necrosis, complex regional pain syndrome, osteoarthritis, as well as joint instability. Okay, we'll move on to some cases. So let's look at these x-rays of a 14-year-old male who was pushed while on the playground. Take a moment and think how you would describe this fracture. So this would be a transverse distal radial fracture or a Smith's fracture. You can tell that the distal aspect of the radius which has fractured is angulated volarly. 9-year-old male fell while playing footy. So this would be an oblique fracture through the mid-diaphysis of the tibia. 89-year-old female with unwitnessed fall at nursing home. This is a classic example of a spiral fracture. You can see that 3D pattern to it of the left proximal femoral shaft with a avulsion fracture of the lesser trochanter. So in someone who's 89-year-old and has an unwitnessed fall at home, remember it's always important to check if they've hit their head, if they've hit their neck, and if you do suspect it, CT brain would be necessary. A 52-year-old male tripped over a dog. So if you look at just the AP view, it's quite difficult to see the actual patella, but if you look at it from the lateral, it's quite clearly a comminuted fracture. Okay, thank you very much for listening, and if you have any questions, feel free to send me an email.